session. That will be with Dr. Anand Pande. Dr. Pande had his MD from the University College of Medical Sciences in New Delhi, his residency in Metro Health, and his fellowship at the University of Buffalo in New York. His clinical interest in research is mainly related to interstitial lung disease, and now we'll be talking about pulmonary complication of biologics and immunotherapy. Thank you.
Thank you, Joe. So I'm a clinician. Most of my time is spent seeing patients, so my talk is going to be rather clinical. And I've been asked to speak on the pulmonary complications of these very wonderful and life-changing medications. Okay. Only disclosure is that is not relevant to this particular talk. And so I'm going to take you on a little trip down memory lane. 2003, I was an intern at Metro Health at that time. And on the left is the FDA approval letter for gefitinib, because that's when this came out. There was a pill that you could take for cancer. Amazing. It was launched with much fanfare. There were celebrations in the medical community, in the oncology community, and especially in the AstraZeneca community. On the right is a magazine advertisement from a Japanese magazine, which includes the words FDA, just so you know. And of course, this was followed the next year by a flurry of lawsuits, because the medication was associated with numerous instances of serious pulmonary complications. And that's the paper in Lancet in 2003 that describes the index case. The lungs are just filled with this diffuse interstitial process. You see the cancer there on the left-hand side. And below is a pathology specimen showing the alveoli flooded with this proteinaceous material and the hyaline membranes that we see with diffuse alveolar damage, which is the pathologic representation of ARDS. So on the left is the list of currently FDA-approved checkpoint blocking therapies. And as you can see, they target different receptors. And while taking the brakes off the immune system is great for killing tumor cells, it can have some unintended downstream consequences. And it can have these immune-related adverse effects in other organs. Now, these most commonly affect the GI tract, the endocrine glands, skin, and the liver. Not so much the lung. So lung is not frequently involved, but when it is involved, it's usually bad. CTLA-4 attenuates T cell activation at a fairly proximal step in the immune response as compared with PD-1. So CTLA-4, anti-CTLA-4 therapy, ipilimumab, generally associated with far more severe adverse effects. In particular, the organs affected being colitis and hypophysitis, as opposed to pneumonitis and thyroiditis, which is more common with anti-PD-1 therapy. So checkpoint inhibitor pneumonitis, this is our working definition of this entity. Quite simply, there's these new opacities on the CAT scan in a diffuse bilateral non-segmental distribution, which is temporally associated with having started an immune checkpoint inhibitor. And this is a diagnosis of exclusion. So it is critical to be able to exclude the possibility of infection or malignancy or even fluid overload in these cases. The NCI grades the severity of organ toxicity on the simple scale. Grade 1 is asymptomatic. So you have the shadows on the CAT scan, but there's no respiratory symptoms at all. Grade 2 symptomatic, grade 3 severe symptoms, grade 4 death. And this is a slide showing the incidence of drug-related pneumonitis, as we understand it, culled from various controlled clinical trials. And you'll see Gefitinib is up there, and you'll see that in, the incidence of pneumonitis with gefitinib in these controlled trials was close to 5%, and the high-grade pneumonitis was 2.5%. Osimertinib is a third-generation TKI associated with maybe 3% pneumonitis, and very seldom associated with really severe disease. Nivolumab, used by itself, is associated with about 2.7% cases of pneumonitis, and high-grade pneumonitis in less than 1% of cases. When used in combination with pembrolizumab, the incidence of pneumonitis is much greater. So as I said, that was from the controlled clinical trials. And this is an interesting paper, which is purportedly a real-world study, which includes patients that would not make it into clinical trials, but patients that we end up seeing in clinic. 6 centers in North Carolina, and looking at their experience retrospectively of lung cancer patients treated with nivolumab and pembrolizumab. The incidence was significantly higher, so almost 10%, and median time to diagnosis, less than 2 months it presents. And importantly, most cases were of high severity, and 27% actually died. They found that this development of ICI pneumonitis was independently associated with the presence of fibrosis on the baseline CAT scan, obstructive lung disease, and pembrolizumab in particular. Other risk factors include the type of cancer that's being treated. So when non-small cell lung cancer is being treated with the same checkpoint inhibitor than melanoma, we have a much higher incidence of pulmonary adverse effects. Combination therapy is particularly bad. So on the right, the graph shows the time to the first admission for ICI toxicity. And you'll see that the group that was receiving the combination of ipilimumab and nivolumab was far more likely very quickly to be hospitalized with a significant pulmonary issue. And now a few pictures. The most fundamental test ordered to make the diagnosis and follow patients over time is the CT scan. And this is what we call an organizing pneumonia pattern. And this is perhaps the commonest pattern that we encounter with drug-induced lung injury, and in particular, checkpoint inhibitor pneumonitis. And these are actually slides of a patient of mine whom I saw in December of 2017. At that time, he was on nivolumab for melanoma, and this is what he had on his CAT scan. So this is sort of a pattern where you've got alveolar opacities, either peripherally or peribronchovascularly, and the very characteristic reversed halo sign, kind of like a coral reef or an atoll sign, is kind of sort of thought to be specific for this. And I thought that there were some pretty good examples of that in this patient of mine. Other CT scan appearances include NSIP. Looking at a whole bunch of review articles, I would estimate maybe 20% of cases would present in this fashion, with diffuse bilateral basal predominant process with ground glass and subpleural sparing, which can progress to a fibrotic phenotype. And on the right-hand side is the dreaded diffuse alveolar damage, which is when the patient is probably in the intensive care unit with extensive bilateral ground glass opacities and areas of consolidation in the dependent areas. Maybe 10% of cases, perhaps. So when should these drugs be stopped? Well, clearly when there's severe or progressive disease, grade 2 or grade 3, while we're doing other studies for diagnostic clarification. And if the patient gets better just by stopping the drug, well, that's pretty good evidence to support the diagnosis. Now, patients who don't have any symptoms, the patients with grade 1 pneumonitis, for example, this is seen, I believe, not infrequently with mTOR inhibitors. Those folks, it might be reasonable to watch. And in osimertinib treated patients, this phenomenon, they've actually given it a name. transient asymptomatic pulmonary opacities. Up to 20% of patients being treated with osimertinib are known to develop these, and this resolves without any treatment, continued osimertinib therapy over the course of about 6 weeks median. And the great thing about it is that it's actually associated, it's a marker for better prognosis associated with longer progression-free and overall survival. What about bronchoscopy? Most of these patients ought to have a bronchoscopy to exclude the other mimics of this condition, including atypical infections and malignancy. We don't know whether the ICI therapy itself increases the risk for atypical infections, but these patients tend to also be on systemic corticosteroids and possibly cytotoxic chemotherapy. As far as biopsy goes, that is not done often and not found to be particularly helpful. What one would expect to find would be some sort of acute lung injury pattern, including organizing pneumonia or diffuse alveolar damage. And these patterns overlap, they're nonspecific, and it's seldom helpful to confirm the diagnosis or guide management. So what do we know about management? Well, everybody gets steroids, we know that. Maybe 1 milligram per kilogram per day for the lower grade versions, and maybe 2 to 4 times that much for higher grade versions. It actually works quite well. So 70 to 80% of patients we would expect to improve, but it's the ones that don't that we really worry about. And so what do we do in those situations? We really don't know what to do, but here are some things that have been done. Apparently, infliximab has been used with great success for immune-related colitis. So that is extrapolated to pneumonitis, and infliximab has been used in these situations. There are reports of use of IV immunoglobulin, which is more commonly used to treat ICI-related myasthenia gravis. The advantage here is that it doesn't blunt the immune response, and we worry that many of the cases, cause of death in many of these patients is actually sepsis, so it's an attractive second-line option. And I found an interesting report on tocilizumab, a single-center experience with a phenomenal response rate of 80% in steroid-refractory patients. I wish I had put in the reference. I apologize. Okay, so a little bit about my patients. Again, this is patient A, gentleman I saw in just last year. He was diagnosed with gastric cancer in June of 2021. This is what his CAT scan of the chest looked like at the time of diagnosis. Then he gets started on Herceptin, Folfox, and pembrolizumab. And that's him in September. And by October, he's beginning to feel decidedly short of breath. You can see the areas of consolidation in the dependent parts of the lung. And that's him in November. Finally, in December, pembrolizumab is discontinued and prednisone is started. And his gastric adenocarcinoma fortunately responded well, and he is in remission. He's still on maintenance treatment. And once the medication was stopped and prednisone started, you're seeing this is his follow-up CAT scan in February. We can see a fair amount of clearing of those previously densely consolidated areas. And this is May of 2022, where it looks like this is resolving with minimal sequelae. Vital capacity jumped from almost 80% to almost 100%. I liked this classification of biologic anti-inflammatory agents by mechanism of action. I'll ask you to focus on the TNF-alpha inhibitors. The most commonly used drugs in these categories are the TNF-alpha inhibitors and the B-cell depletion agent rituximab. And I'm sure we've had a talk earlier today about the infectious potential side effects with these medications, but I'd like to just mention that with TNF-alpha inhibitors, granulomatous lung disease has been described and is often talked about. And with rituximab, there are reports of organizing pneumonia and acute interstitial pneumonitis. Drug-induced sarcoid-like reactions are a quaint entity that are, again, often discussed, described as a systemic granulomatous tissue reaction, which is indistinguishable from sarcoidosis, but apparently starts after you start a certain offending drug. Well, how do we know it's not a coincidence? If you stop the drug and it goes away, then that's pretty good evidence. So the two categories of drugs with which are associated with sarcoid-like reactions that I would like to focus on are immune checkpoint inhibitors and anti-TNF antagonists. So there's a French registry that reported of about 1,000 patients treated with checkpoint inhibitors, of whom just 2% developed immune-related adverse events. And of them, sarcoidosis was only noted in 0.2%. TNF antagonists, the fact that they can develop granulomatous reactions is quite paradoxic, given that TNF alpha is critical to granuloma formation. So this is very odd, but this is well described, particularly for etanercept. It develops late, about a couple of years after drug initiation. 60% of these patients will require some sort of treatment. And here's another retrospective French study, which shows that this is extremely uncommon, so 0.04%. So while these are things we discuss and talk about a whole lot, they actually occur very infrequently. And finally, a word about rituximab. So this was a paper in Rheumatology, a review of 121 patients with rituximab-induced drug-related pneumonitis, which was actually fatal in 15% of cases. And it was followed quickly by a letter to the editor in the same journal by one of the other rheumatologists saying, hey, listen, this is a rheumatology journal, and why are we bashing rituximab? In this study, almost 95% of the patients were cancer patients being treated with rituximab, and the patients with rheumatologic illness here were about 3%. And so the dose of rituximab used for cancer treatment and for rheumatologic conditions is very different, lower dose for rheumatologic conditions. And they looked at those 3% of patients and found that they very infrequently ran into problems. And this is my second patient. So this is a gentleman with a left lower lobe mass and a lesion on his right 10th rib, had a needle biopsy in 2016 confirming melanoma. And he was on nivolumab and ipilimumab, which was started directly after. And in August, a few weeks later, he has labs and he has profound hypercalcemia and acute renal failure. So he has a PET scan later that month, which is reported terrifyingly for the patient as showing marked disease progression, FDG avid lymph nodes everywhere, lighting up like a Christmas tree, including lesions in the lungs, in the spleen, skin, and in the bones. So he came down to see me. And at that time, we were learning about this, so I was uncertain and careful, but I thought about it very carefully, and I convinced myself that this was some sort of granulomatous response to the ICI, and treated him with a little bit of prednisone, 30 milligrams per week and down tapering every week. Started Plaquenil, which works well in granulomatous disease. He had no respiratory symptoms. I suggested continuing the nivolumab, and his calcium levels returned to normal, kidney function improved, and that was him in August. And exactly 1 month later, the repeat CAT scan was dramatically different. I mean, it said like, this is a miracle cure or whatever. So everything settled down within a month, and I recommended that we continue treating him with the nivolumab, and we'll keep him under surveillance, and if there's a problem, we'll react accordingly. But and this is his couple of representative CAT scans of him in July of the following year, everything completely cleared up. So important questions, is it safe to restart the ICI if our patient has a serious adverse event? I guess it depends. How severe was the adverse event? And if it's pretty severe, then on a case-by-case basis, once the symptoms and the radiologic abnormalities have completely resolved. If it was a pretty severe grade 4 reaction, then probably shouldn't try it again. And then, existentially, is it even necessary to restart them? So melanoma, and there's a couple of studies here that I'll point to. It was found that melanoma patients who were treated with combination nivolumab and ipilimumab and stopped treatment because of toxicity in the first 4 months actually had very similar rates of progression-free survival and observed survival as compared with those who remained on treatment. And while this was seen in the melanoma population, similarly in the non-small cell lung cancer population, a very similar phenomenon was noticed, that those who stopped the medication because of adverse effects did just as well as those who continued it. And with that, I thank you for your attention. And I'll take any questions.
Any questions? No.
Thank you very much.
Thank you. This was very nice. Thank you. So